Good evening, guys. And today, our topic of discussion is about these parameters and how these parameters will going to affect the renal plasma flow, GFR, and filtration fraction. So, what is renal plasma flow? It is the amount of the blood or plasma that is flowing towards the renal system, and it is approximately 600 ml per minute. Okay, and out of 600 ml, approximately 120 ml is going to pass through the filtration system, and it's nothing but a glomerular filtration rate. Filtration fraction is the division of these two, in which the GFR is numerator and the renal plasma flow is a denominator, as indicated in this formula. So let's discuss these parameters one by one. First of all, the afferent arteriole constriction. Okay, let's discuss theory first and then we fill up the chart. Afferent arteriole constriction. What are the most important constrictors of afferent arterioles? These are epinephrine and norepinephrine. These are released in response of the sympathetic nervous system. What would be the effect if the afferent arteriole will constrict? Let's see in the diagram that if we constrict this part, what do you think, that renal plasma flow will increase or decrease? The renal plasma flow will decrease because the blood vessel is constricted and the amount of blood passing through that area would be reduced, as thinking logically. So it means that renal plasma flow would be reduced. And what about the GFR? When the renal plasma flow is reduced, hydrostatic pressure in the capillaries would be reduced. It means that less amount of blood is present here, less amount of pressure is being exerted. So it means that GFR would be reduced accordingly. So GFR would be reduced. And what about the filtration fraction? As I've told you that the filtration fraction is the division between GFR and renal plasma flow. So if the GFR and the renal plasma flow are decreasing proportionally, it means that both are decreasing at the same time. So it means that filtration fraction would remain constant in that case. It means that it is constant. I will represent it as C. So let's take an example that before constriction, the renal plasma flow was 600 ml per minute and GFR was 120 ml per minute, right? So filtration fraction would be GFR over 600, it's 0.2. 20% of the renal plasma flow is being filtered, right? After constriction, the renal plasma flow reduced to 300 ml and GFR reduced to 60 ml. But dividing these two, we obtain the same result. It's 0.2. It means that if both the numerator and denominator are decreasing proportionally, so the sum, the equivalent of them would not change. It would remain constant. In this condition, the filtration fraction is constant. Okay, we have discussed one. So let's take it. Afferent arteriole dilation. Think logically that if we dilate this part, let me remove this. If we dilate this part, okay, the amount of the renal plasma flowing through the arteriole would increase or decrease. It would increase, right? So that's it has more space for flowing, so it would increase. And what about the GFR? When the blood here in the inside the capillaries would increase, it means that there's high hydrostatic pressure of the capillaries. With the high hydrostatic pressure of capillaries, the GFR is going to increase automatically. Okay, so it's an arrow of increasing GFR. And what about the filtration fraction? As I have told you that if both numerator and denominator will increase at the same time proportionally, the filtration fraction would remain constant. Let us take an example of the afferent arteriole dilation, that before it was 0.2, right? And after dilation, the renal plasma flow will increase to 900 and GFR will increase to 180, but their equivalent is zero point 0.2, as same as before dilation. So it means that filtration fraction is not going to change, it would remain constant. We have discussed another parameter. The third one is that efferent arteriole constriction. It means that the efferent arteriole is going to constrict, but there are two conditions in the constriction. First is the moderate constriction, and the second is the severe constriction of efferent arteriole. Efferent arteriole undergoes constriction moderately. Okay, if this area is constricting moderately, so the renal plasma flow will decrease, right? Renal plasma flow through that arteriole would decrease. And GFR, what about GFR? If the blood through passing through here will decrease, so blood here will increase and the hydrostatic pressure in the capillaries will increase. It means that GFR will increase. But what about filtration fraction? Filtration fraction was the ratio between the GFR and renal plasma flow. It means that when we constrict the efferent arteriole moderately, it means that GFR will increase and renal plasma flow will decrease, but the filtration fraction would increase because the numerator is increasing. So filtration fraction will increase. And when we constrict the efferent arteriole severely, and this is an very paradox condition, that when we constrict the efferent arteriole severely, okay, we are constricting it very severely, renal plasma flow will decrease same. Okay, and what about the GFR? It was increasing in case of moderate constriction, but in case of severe constriction, the severe constriction GFR would increase initially, but after that a lot of filtrate is being produced from here. The remaining plasma became concentrated with proteins, right? The remaining plasma would have increased oncotic pressure. The oncotic pressure exerts a negative filtration force. It means that GFR after some time with severe constriction would automatically decrease. It is because that the remaining plasma will have more concentration of protein as normally. So renal plasma flow and GFR in case of severe constriction of efferent arteriole would decrease both. And filtration fraction, because both are decreasing proportionally, so filtration fraction would remain constant. What about total plasma proteins in the blood? The total plasma proteins can be increased in case of hyperproteinemia, or it can be increased due to multiple myeloma when the plasma cells are producing abnormal beta globulins. So it is because that when the plasma protein concentration is increased, it means that oncotic pressure would increase, capillary oncotic pressure. Okay, so it is a negative filtration force, right? But it does not have any effect on the renal plasma flow. It will not affect the renal plasma flow, these both conditions. Either if the proteins are increasing or if they are decreasing, they will not affect the renal plasma flow, but they will affect the GFR. If there is increased plasma protein concentration, it would decrease GFR because it's an opposing force. And if there is decreased plasma protein concentration, it would increase GFR. Okay, and filtration fraction, because GFR was numerator. Okay, it means that in case of the high protein concentration, GFR would decrease and the filtration fraction would also decrease. And in case of low plasma protein concentration, GFR was increasing, so the filtration fraction would also increase. This chart, you do not need to memorize this chart, just think logically and the gaps would be filled automatically. After that, there are some cases, there are three cases we will discuss one by one. First of all, is a patient consume a large amount of caffeine and it affects the renal plasma flow, GFR, and filtration fraction, and how these parameters will be changed by ingesting or taking the caffeine. Caffeine is a vasodilator. It is a vasodilator of afferent arteriole. It means that afferent arterioles are being dilated, so it will increase the renal plasma flow. It will increase the GFR, but these both are increasing simultaneously, so there will be no change in the filtration fraction. This seems to be correct answer, but there is option increased FF, so it's not correct. The correct option is C. Okay. The second is the patient experience increased renal plasma flow and GFR. What happens to the filtration fraction? It is indicating that it's GFR and renal plasma flow. It's increasing renal plasma flow and increasing GFR, so it would remain constant. The filtration fraction will not change, no change in filtration fraction. The third case is that a 42-year-old male is brought to emergency department after a roadside accident. It indicates some sort of bleeding, external or it can be internal. And the patient has hypovolemic shock. It means hypotension and tachycardia. Sympathetic nervous system is working and RAS system is also activated, but he receives anti-inflammatory drugs. It means the non-steroidal anti-inflammatory drugs he was receiving after the roadside accident which further deteriorate his condition. What is the cause of the kidney deterioration? When there is hypovolemic shock, there is a sympathetic nervous stimulation and it will cause constriction, vasoconstriction of the arterioles. But kidney has its autoregulatory mechanism and it releases prostaglandins, right? And prostaglandins will dilate that constricted arteriole. But when we give that patient NSAIDs or anti-inflammatory drugs, they block the production of prostaglandins by inhibiting the enzyme known as cyclooxygenase. It means that when prostaglandins are not produced, so autoregulation of the kidney is hindered, and in this condition, it will further severe the function or the condition of that patient. The last points I need to mention here is that what about ureteric obstruction? If there is any obstruction or stone or it condition like urolithiasis in the urinary tract, it can be either in ureters, urinary bladder, or even in the urethra. The pressure inside the Bowman space will increase and it will increase the Bowman's hydrostatic pressure. Okay, the pressure builds up in the nephron, it will build up in the Bowman's capsule, and it will decrease the GFR because the Bowman's hydrostatic pressure is an opposing force of filtration. When GFR is reduced and renal plasma flow will not be changed because of ureteric obstruction, when GFR is reduced, the filtration fraction would be reduced automatically. The two important things also I need to mention here is that unfiltered components and filtered components. Most of them you know that cells, the RBCs, WBCs and platelets do not filter. Plasma proteins which are very large like albumins, globulins and fibrinogen also not filtered. The substances that are bound to the plasma proteins, for example, bilirubin is bound to plasma proteins, calcium, fatty acids, drugs, and thyroid hormones T3 and T4 are also bound to the plasma proteins. The substances that are bound are not filtered, they never undergoes filtration process because they have like linkage to the plasma proteins and they are not filtered in any case. But what are filtered components? The water, as you know, electrolytes, sodium, potassium, calcium, which was not bonded to plasma proteins, and magnesium. Also, anions like chloride and bicarbonates, urea, creatinine, metabolic waste products, glucose, amino acids, and ketone bodies, which are then reabsorbed back in the PCT, proximal convoluted tubule, and organic acids which are actively secreted. These all are like filtered components of the nephrons. Low molecular weight proteins which are insulin. Insulin is a hormone, right? But it is made up of proteins, protein subunits. Insulin is filtered, but it then get reabsorbed in the PCT. This insulin is catabolized and its amino acids are used for gluconeogenesis. The definition for gluconeogenesis is that the synthesis of glucose from non-carbohydrate sources. It can be either fatty acids, it can be either amino acids. So insulin catabolism in the PCT cells will release amino acids, and these amino acids are used for gluconeogenesis. There are two organs in the body that regulate gluconeogenesis. First is the liver and second is the kidneys. The second low molecular weight protein is hemoglobin. Hemoglobin is normally bound to RBCs and they are not released because they are nephrotoxic. How they are nephrotoxic? When there is incompatible blood transfusion between two patients or two people, it results in agglutination of our blood cells or the donor blood cell in our bloodstream. The agglutinated blood will release the free hemoglobin, and this hemoglobin is filtered freely, and after that it is reabsorbed by PCT. It's broken down by these cells and release iron. That iron which is released from hemoglobin is nephrotoxic. It means that if this iron is accumulated in the nephron, it will result in acute tubular necrosis, and it's a complication of incompatible blood transfusion. There are two other substances which are unnatural, like inulin and para-aminobutyric acid. These both are very important because these are used as marker for measuring of either GFR or renal plasma flow. Inulin is used as marker for the measurement of glomerular filtration rate, and para-aminobutyric acid is used as marker for measuring or estimating the renal plasma flow. And this was for today. I hope you understand this lecture and just try to make this chart and these things by your own hand, because when we write there is coordination between our brain and our hand, so it results in like rapid learning process. Okay, I will see you in the next video. Till then, take care and goodbye.